A very good evening to one and all who have joined us here today. Today we'll be having the part 2 of the NEET PG Rapid Revision Series General Medicine. Dr. Rashmi Shivram ma'am has joined us for the second day. Without any further ado, we'll start the session. Ma'am, over to you.
Just a minute. So very good evening to all of you. Today is the part 2 discussion of continuation of what we had yesterday. So yesterday we had concentrated mainly on the image-based questions, and I hope it was very high yielding and very useful for you. It is not only for the NEET PG goers, but also for the final year students also. I think it will be very useful. And right now it is NEET PG time. So all of you can concentrate, and like yesterday, I would like to have some participation, and you can try to answer the questions along with me. And you can just put your answers in the chat box. Okay. Yeah. So shall we start? The first question, a patient presents with frequent urination, nocturia and enuresis. 24-hour urinary volume was found to be around 7 liters. The urine osmolality was 260 milliosmoles per liter. ADH was 0.8 picogram per ml. And MRI showed the absence of a bright spot on T1 imaging. So what is the most likely diagnosis? So is it nephrogenic diabetes insipidus, primary polydipsia, central DI, or mannitol? Is it because of mannitol infusion? So there are some key points in this question that I would like you to be aware of. So first one is the patient is having frequent urination, and you can obviously see that there is polyuria. The patient is also having some nocturia. Okay, so we are this is basically how do we approach polyuria? That is the question that is being asked, isn't it? And you also have to find out the urine osmolarity. For that, we need to know the normal urine osmolarity and what is the ADH value. So let us see how to approach polyuria. If any of you can tell me the answer, that would be very great. Okay, so we'll see how to approach polyuria. So once the patient is having polyuria, we define it as more than 3 liters per day along with nocturia. So what you should be doing, you should first do the urine osmolality, right? Urine osmolality. If it is less than 300 milliosmoles, that means it's a very dilute urine, which is obviously true because it's a polyuria. Then what happens? We have to do the ADH levels, right? We have to do the ADH level. If it is less than 1 picogram per ml, if it is more than 1 picogram per ml, it means that the patient is having a nephrogenic diabetes insipidus. So what does it basically mean? The ADH level is good, but the patient is producing polyuria. The patient is not able to concentrate the urine despite ADH being high. So what does it mean? The ADH receptor, there is insensitivity, isn't it? So the ADH receptors are not functioning properly. ADH is there in adequate concentrations, but the receptors are not functioning properly. So the patient is having a polyuria. So that is meant by nephrogenic diabetes insipidus when the ADH levels are high. So it is more than 1 picogram per ml. So if the ADH concentration is less than 1 picogram per ml, what will happen? You have to do an MRI brain, right? You have to do an MRI brain. So what are the other two important causes of polyuria? One is central diabetes insipidus and the other is primary polydipsia, isn't it? So we do an MRI brain. So if the MRI brain shows a pituitary bright spot, pituitary bright spot present, pituitary bright spot absent. If it is present, then it is a primary polydipsia, right? Primary polydipsia. If the pituitary bright spot is absent, then it means that it is a central diabetes insipidus, right? Then it means that it is a central diabetes insipidus. Okay, so in this question, when you see the osmolarity is less, it is less than 300 milliosmoles, and the ADH is also less than 1 picogram per ml. And the pituitary bright spot is absent. So the answer for this question will be central diabetes insipidus. Okay, so how do you treat these patients with nephrogenic diabetes insipidus? You essentially say that the patient should be having a low salt diet, and you can give the patient hydrochlorothiazide. You can give the patient thiazides, especially hydrochlorothiazide. Okay, and for patients with central DI, what is the treatment? It is desmopressin. Right? It is desmopressin nasal spray. Okay? Yes. So this is how the treatment also we have concentrated on this question. Okay? Yes. So let's move on to the next question. A 50-year-old patient develops prosthetic valve endocarditis 2 years after valve replacement surgery. So which of the following organism is the most likely cause? Is it Streptococcus? Is it Staphylococcus aureus? Is it Cons? Or is it one of the Hackett organisms? Okay, so there are a few things that you must remember in this question. One, it is prosthetic valve endocarditis. And the other, the duration. It is 2 years after the replacement surgery. Isn't it? So, how do you approach this question? What could be the answer? If any of you could guess, that would be great. Yes? So, you can try guessing. Okay? So, you can try answering the question also in the meantime. So, how do we approach this? So, in a patient with native valve endocarditis, right? Native valve endocarditis, what is the most common organism? It is Streptococcus, right? It is Streptococcus. Native valve endocarditis, the most common organism is Streptococcus. If it is a hospital-acquired infection, it will be Staphylococcus. But most likely, if it is a native valve endocarditis, the most common organism will be Streptococcus. And in few cases, Enterococcus is also possible. Right? Streptococcus, Enterococcus is also possible. So when it comes to prosthetic valve endocarditis, we need to remember the duration after the surgery. Right? Prosthetic valve endocarditis, we need to remember the duration after surgery. Okay, so how do we think about the duration? First, if it is within 2 months, it is most likely due to cons. What is it? Coagulase negative Staphylococcus. Right? Within 2 months, it is coagulase negative Staphylococcus. Within 2 to 12 months, again, it is cons. Right? So essentially, within the first year, if it is happening, it is most likely due to cons. Okay, if it is more than 12 months, what is the most likely organism? It is Streptococcus. Again, it is Streptococcus. Okay, so if it is more than 12 months, if it is more than 1 year, the incidence is more because of Streptococcus infection. Okay, so prosthetic valve endocarditis, within the first year, it is most likely to be due to cons. If it is more than 1 year, it is because of Streptococcus. Okay, and if it is an IV drug abuser, what are the main points regarding this? The patient will be having a right-sided endocarditis mostly, right-sided infective endocarditis mostly, and the organism will be Staph aureus, especially MRSA, right? Staph aureus, especially MRSA, and right-sided infective endocarditis will be more common. Okay, so few more things that I want to highlight when we talk about endocarditis. Yes, Dr. Preeti, correct. Streptococcus is the wonderful answer. So Streptococcus is the answer for this question. Okay, but in the meantime, I want to discuss some more points about infective endocarditis. Okay, so what are the other things? So what are Janeway lesions? There are some named lesions that we should know about. So what are Janeway lesions? Janeway lesions are erythematous macules on the palms and the soles. Okay, they are erythematous lesions on the palms and the soles. Okay, then what are Osler's nodes? Osler's nodes. There in the fingertips, you have some nodes here. I mean, like P-shaped macules which develop. These are called Osler's nodes. Janeway lesions are, erythematous macules on the palms and the soles of the feet. Osler's nodes are, like protrusions developing on the fingertips. These are called Osler's nodes. And what are Roth spots? Basically, these are fundus findings. Right? Basically, these are fundus findings. So when we talk about infective endocarditis, it becomes mandatory that we know the criteria, isn't it? So it's mandatory that we know the criteria nowadays. So the criteria has been modified recently. So I would just like to highlight what the criteria is. Okay. So like essentially we have the major criteria and the minor criteria. Okay. So when it comes to infective endocarditis, blood culture plays a very, very important role. Okay. So this criteria will generally revolve around the blood culture. So when we talk about the major criteria, right? First, the major criteria. The first one will be a positive blood culture. A positive blood culture, right? Which is a typical organism should be grown from the blood culture, which is taken in 2 separate regions. You can either take a right femoral and a left brachial or something like that. You can have 2 blood cultures which are taken in 2 different regions, and that you should grow a typical organism. So what are the typical organisms? You can have a Streptococcus viridans, right? Typical organisms. We can have Streptococcus viridans, Streptococcus galactolyticus, Staph aureus, or a Hackett group of organisms. right? These are all the typical organism, and this organism should be grown in at 2 blood cultures which are taken in 2 different regions. Okay, that is one criteria. And the other one will be if there is a single positive blood culture for Coxiella, right? Typical organisms, it should be grown in 2 regions separately. If it is a single positive blood culture, that one should be Coxiella. Then you can say that this is a infective endocarditis. Okay, what is the other evidence? It is echocardiographic evidence. Echocardiographic evidence, you can either do a transthoracic echocardiography or a transesophageal echocardiography. And you should be able to demonstrate the vegetation. Sometimes it might look like a thrombus also. So you must be very clear in identifying the vegetation. So you should do a positive, it should be a positive blood culture. If it is a single blood culture which is positive, it should be Coxiella, and there should be echocardiographic evidence. These are the major criteria. So when we move on to minor criteria, right? So when you move on to minor criteria, the first one is that there should be some predisposing factor, right? The first criteria should be, there should be some predisposing criteria for the patient, like he should have had a IV drug abuse, or there should be some previous cardiac disease, or there should be some valve replacement which has happened. There is some predisposing criteria for the infective endocarditis to happen. Okay, so first point in the minor criteria will be that there should be a predisposing criteria. Okay, the second one will be the patient should be presenting with fever, which is more than 38 degrees with chills and rigors. The patient should be having, the presentation should be with fever and chills and rigors. Then you have something called the vascular phenomena and the immunologic phenomena, right? So often we get confused what is the vascular phenomenon and what is the immunological phenomenon. So we need to remember this very clearly. The vascular phenomenon are usually the infective endocarditis can embolize. So these are called arterial emboli. Arterial emboli. Right? You can have arterial emboli. You can also have infarcts. Okay? Infarcts can be there. Then you have a mycotic aneurysm in the blood vessels of the brain. Right? Mycotic aneurysm can be there. Or you can have an intracerebral hemorrhage, or the named one which I was telling you, Janeway lesions. Right? So named one, that one you must remember in the vascular phenomena, that is Janeway lesions. Right? So let's move on to the immunological phenomena. Immunological phenomena. So immunological phenomena will be, so the patient can have Roth spots, right? Oscillus nodes. All the names ones are coming here. The named one under vascular phenomena, the one will be Janeway lesions. The other ones will come under immunological phenomena. So you have Roth spots here, you have Oscillus nodes here, and you can have glomerulonephritis. The RA factor can become positive. Okay, so these are all the immunologic phenomena that you will be seeing in this patient. So there is one more thing. The fifth minor criteria will be that there is microbiologic evidence. That is, the blood culture will be positive. Blood culture will be positive, but it will not be satisfying the major criteria. It will not be a typical organism, or it will not be Coxiella burnetii. Okay. So what will be, there will be some blood culture which has been grown here, but it is not a typical organism which has been grown. Okay. So these are the major this comes under blood culture will be one criteria, and this will be the second criteria. So you have 2 major and 5 minor criteria. Okay, 2 major and 5 minor criteria. So how do you say that there is definitive endocarditis? So definitive endocarditis is when you have 2 major or 1 major plus 3 minor criteria. Or if you're not able to satisfy any of the major criteria, then you can have all the 5 minor criteria to be positive. Then you say that the patient is having definitive infective endocarditis. Okay, so 2 major or 1 major plus 3 minor and or 5 minor criteria should be positive. Okay, so this is a small discussion about the endocarditis. So one last point that I would like you to remember, when all do we give prophylaxis for the patient? Okay, to prevent them from developing infective endocarditis, especially the question will talk about a dental procedure, right? So the patient, they will say that the patient is going for a dental procedure. Will you give infective endocarditis prophylaxis for this patient or not? So in that cases, we should remember if the patient is having a prior endocarditis, okay, or the patient is having a prosthetic valve, or is having an LV assist device, or if the patient has having a congenital heart disease which has been repaired or unrepaired, congenital heart disease, or if the patient is having a cardiac transplant, post-cardiac transplant patient. Okay, so in these patients, you should be giving the patient endocarditis prophylaxis. Infective endocarditis prophylaxis should be given. Right? Yes. So I have covered the topic about infective endocarditis in brief. Okay. So this question is done. So let's move on to the next question. According to the Berlin definition, moderate ARDS is characterized by all except PaO2 by FiO2, 200 to 300 millimeters mercury, bilateral interstitial infiltrates, symptom onset within a week, and there is no cardiac failure on echocardiography. So tell me, what is the Berlin definition and how do we characterize ARDS? So can any of you answer this question? What is moderate ARDS by this definition? Okay, so before we go on to that, we can say ARDS, what type of respiratory failure does it cause? ARDS causes type 1 respiratory failure. Okay, type 1 respiratory failure. So what do you mean by type 1 respiratory failure? There is hypoxemia. There is essentially no carbon dioxide elevation happening. Okay, that is type 1 respiratory failure. Type 2 respiratory failure is where you have hypercarbia. Okay, type 2 respiratory failure is when you have hypoxia plus hypercarbia. So when does this happen? That happens in COPD patients, acute exacerbation of COPD. So the status asthmaticus, that is when you have type 2 respiratory failure. Then you have type 3 respiratory failure, which happens essentially in patients with perioperative atelectasis. When the patient post-operatively is having an atelectasis, the patient will develop type 3 respiratory failure. And when there is type 4 respiratory failure, when the patient is having respiratory muscle which is not well perfused, right? The respiratory musculature is not well perfused. Respiratory musculature is not well perfused. So that's when you have type 4 respiratory failure. Okay, so type 1 respiratory failure, ARDS, type 2 COPD and acute exacerbation of asthma. Then type 3 respiratory failure will be in post-operative atelectasis and type 4 will be respiratory muscle hypoperfusion. Okay, so can any of you answer this question? According to the Berlin definition, moderate ARDS is characterized by all except PaO2 by FiO2 between 200 to 300 millimeters mercury, bilateral interstitial infiltrates, symptom onset within a week, no cardiac failure and echocardiography. So ARDS is acute respiratory distress syndrome, right? So this is one of the criteria. The symptom onset should be within a week. It should be an acute onset. So that is one of the criteria, obviously. So what do you find on the chest X-ray? You will have bilateral diffuse infiltrates, interstitial infiltrates. Again, that is one of the criteria. So the third criteria will be there should be no other reason which is explaining the ARDS, which is explaining the respiratory distress. Like the patient should not be in volume overload. The patient should not have an exacerbation of COPD. Okay, so that in those conditions, you can consider the patient to be having ARDS. But the characterization of mild, moderate, and severe will be based on the PaO2 by FiO2 values. So let me just write it down for you. Right? Option B. So Dr. Strength Bulkar says option B. So we'll just see the answer. So the first criteria will be the patient, it should be an acute onset. Right? Acute onset of illness. Acute onset of respiratory distress. The second one is the patient should have bilateral interstitial infiltrates on the X-ray radiologically. The third one will be the patient should be having a respiratory failure which is not explained by other conditions like a volume overload or COPD exacerbation Okay. And the fourth one is PaO2 by FiO2 ratio. Right? Based on this, we characterize as having mild, moderate, and severe. Right? So when do you say it is mild? When do you say it is moderate? When do you say it's severe? So mild will be between 201 to 300 millimeters mercury. Then moderate will be 100 to 200 millimeters mercury. And this severe will be less than or equal to 100 millimeters mercury. That is when you say that the patient is having a severe ARDS. So in this patient, they have given a pressure of 200 to 300, which is definitely not moderate. It is mild ARDS. So characterized by all except, so this will be the answer for this question. So the answer for this question is option A, PaO2 by FiO2 between 200 to 300 millimeters mercury. Okay. Yes. So let's move on to the next question. Which of the following is not a common feature of allergic bronchopulmonary aspergillosis? Is it distal bronchiectasis? Is it a cough? Is it wheezing? Is it raised serum IgE levels? Okay, ABPA, this is a very frequently asked question. I think you should know something about a bit detail about ABPA because it is very easy to get misled in the question. Okay, the options will often be very confusing when it comes to this question. So we need to be very clear about a few points about ABPA. Okay, so I would like one of you to try the answer. Which of the following is not a common feature of allergic bronchopulmonary aspergillosis? Is it distal bronchiectasis? Is it cough, wheezing, raised serum IgE levels? Okay, so let's see what is ABPA. ABPA is an allergic reaction. It's a hypersensitivity reaction. Right? It is a hypersensitivity reaction to the Aspergillus antigen, which is Aspergillus fumigatus. Usually it's Aspergillus fumigatus. Right? So that is Aspergillus fumigatus. So this is usually seen in patients who have asthma or cystic fibrosis or some kind of immunosuppression. Right? Or some kind of immunosuppression. Okay, this is most commonly seen in patients who are having asthma, cystic fibrosis very commonly. Okay, so what do you find in these patients? There are some X-ray features and there are some other features you should remember. So when we talk about the X-ray features or the radiological features, you will have a central bronchiectasis. You must remember it is not distal bronchiectasis, it is central bronchiectasis. Yes, Dr. Preeti, very good. It causes central bronchiectasis. You're very correct. So it causes central bronchiectasis. Central bronchiectasis. That's right. Okay, it causes central bronchiectasis. What are the other things that you can find on the X-ray? You can find a mucoid impaction. Right? You can find a mucoid impaction. There is hyperinflation of the lung fields. Hyperinflation of the lung fields. You can also have a honeycombing pattern. Right? You can also have a honeycombing pattern on the radiology. So these are all very, very important points. And the perihilar infiltrates can be there. You can also have some perihilar infiltrates. Okay, these are all radiological findings. You can have a central bronchiectasis, you can have mucoid impaction, you can have a hyperinflated lung fields, you can have honeycombing and also perihilar infiltrates. Okay, so when we talk about the criteria for this, the first thing is the patient should have patient should be having asthma, right? The patient should be having asthma or wheezing. The second is there should be a positive skin test. You do a skin test for this Aspergillus antigen and the patient should be reacting to that because this is basically a hypersensitivity reaction, right? So the skin test should be positive for Aspergillus antigen. Okay, and the patient should be having IgE or IgG antibodies for Aspergillus fumigatus. Okay, IgE or IgG. Mainly it is IgE antibody because it's a hypersensitivity reaction. You should remember the immunoglobulin will be IgE for the Aspergillus antigen. Right. The fourth point will be there will be transient pulmonary infiltrates. Right. You will have transient pulmonary infiltrates. I told you in the X-ray finding you will have pulmonary infiltrates. So the patient will be having transient pulmonary infiltrates. You will also have sputum culture positive for Aspergillus. Right. Sputum culture positive for Aspergillus. And the sixth point is you will have eosinophilia plus IgE elevation, IgE antibodies. Right? Eosinophilia and the total IgE will be elevated. So in this question, we had talked about wheezing, presence of wheezing, the presence of IgE antibodies, and also it's a central bronchiectasis. So the answer to this question will be, it is not distal bronchiectasis, it will be central bronchiectasis. So otherwise you'll be having cough, you'll be having and wheezing and also serum IgE levels. So this will be the answer to this question. It is not distal bronchiectasis, right? Okay. So how do you treat this patient with Aspergillus, ABPA? How do you treat the patient? So basically the mainstay of treatment will be steroids. You must remember this. The mainstay of treatment will be steroids. Along with that, you should be also giving antifungals. Okay. So what is antifungal that you will prefer? It will be itraconazole. Right? The antifungal that you will prefer, it will be itraconazole. Okay. The mainstay of treatment will be steroids. Along with that, you also need to have itraconazole. Okay. Yes. So let's move on to the next question. A 12-year-old boy, a known case of type 1 diabetes mellitus, and was brought to the emergency with complaints of confusion and drowsiness. His mother feels that he is breathing very fast. On examination, his mucous membranes are dry with BP of 70/50. His random blood sugar is 415 milligram per deciliter and urine ketones are positive. So what is the next best management in this patient? Right? So I would like one of you to try this answer. So essentially the patient is having type 1 diabetes. It's a small child. He's a adolescent almost. Okay, he is presenting with confusion and drowsiness. His mother feels there is tachypnea. He's breathing very fast. His mucous membranes are dry. That means there is dehydration. And the BP is 70/50 millimeters mercury. He's hypotensive. His random sugar is high. And urine ketones are positive. So what do you think this patient is having? This patient is having a DKA, right? So Dr. Singh says it's option A, 2 to 3 liters of normal saline over 1 to 3 hours. Okay. So let's discuss the answer for this question. Okay. Very good interaction. I'm very happy about the interaction today. So we'll see what the answer could be. So this patient is actually having DKA, right? Diabetic ketoacidosis. But how do you say that the patient is having DKA? You know that the patient is having a blood sugar which is high and urine ketones are positive, but we still do not know the acidic status of the patient. We still do not know the pH of the patient, right? To say whether it is mild, moderate, or severe, or what, how much of fluid should we give, how much should we correct the bicarbonate, how do we actually guide his treatment? So before doing all these things, we must do an arterial blood gas for the patient. We must do an ABG as a baseline to find out how acidic the patient is, how acidemic the patient is, and how to guide the treatment. For that, we need to do an ABG first. Okay. So how do we manage a patient with DKA? We should look at the condition of the patient. So if the patient is not very dehydrated, there is only minimal dehydration, he's not vomiting or anything, he's able to tolerate oral fluids. So in this patient, what will you do? You will actually give subcutaneous plus subcutaneous insulin you'll be giving the patient, and you will also give oral hydration. Right? You will also give oral hydration for this patient. Okay, so when there is minimal dehydration, what you will be doing, you'll give subcutaneous insulin to the patient, and you'll also give the patient oral hydration. Okay, but if the patient is having a shock, like in this patient, the BP is very low, it is only 70/50 millimeters mercury. So if the patient is in shock, what will you do? You will have to do, if the GCS is also low, if the patient is having a low GCS, and if the patient is also in shock, what should you do? You should first secure the airway, breathing, and circulation. That is very, very important. You should not forget this. So you should just check the airway. You should secure the airway. You should check for the breathing and the circulation. And then what you should be doing is you should give a fluid bolus. Right? You should give the patient a fluid bolus. Okay. So the patient comes to you in moderate dehydration. Moderate dehydration. Right? But the patient is having a lot of vomiting. He is not able to take oral liquids. Okay, he's not able to hydrate himself orally. So what do you do for this patient? You give IV saline. How much do you give? 10 ml to 20 ml per kg. Okay, over half an hour, say half an hour. And then you see how the patient is. And then you just correct the rest of the fluids over 24 to 48 hours. You correct the fluid deficit over 24 to 48 hours in this patient. Okay, and along with that, you also have to supplement KCl injection. You have to also supplement KCl, because when you give, when you're supplementing this, when you're giving insulin to reduce the sugars, there will be a shift of potassium. There will be hypokalemia, which will be precipitating hydrogenically. So you should be giving the patient potassium. You should check the electrolytes frequently, and you should be giving the patient potassium chloride. Okay. So what is the role for sodium bicarbonate in these patients? Will you be giving the patient sodium bicarbonate? Sodium bicarbonate is generally not advised. So when you correct the dehydration part, this acidemia and everything will get corrected by itself. Once you reduce the sugars and once you reduce the dehydration part, the bicarbonate will also come back to normal. Okay, so first baseline, we need an ABG. After that, we have to correct the dehydration. Okay, so this fluid bolus should be administered immediately. You need to keep a constant check on the electrolytes of the patient, and also you need to keep a check on the BP of the patient. Okay, so hydration is very, very important. Hydration is the key to treat DKA. Okay, so the answer for this question is, first you do an arterial blood gas, because we need a baseline. After that only we can start treating the patient. Okay, so once you do this, patient is shocked, and this one, what should you do? You should be giving the patient insulin. Okay, so insulin is also important, but first you correct the hydration part. So insulin, what should you do? After giving the fluids, once you start the fluids, after 1 hour, you can start giving insulin. So you have that much of time. Okay, so the priority is not insulin. The priority is correcting the dehydration. Okay, so insulin, how much will you be giving? You should be starting with 0.05 to 0.1 units per kg per hour. Yeah, so because of hypotension, insulin is not the first thing. First, you should be giving IV fluids. After that, you should be giving the patient insulin. Okay, then you have to do an hourly CBG and monitor the patient. You should be giving an hourly CBG and monitor the patient. Okay, so the mother was saying that the patient is having a difficult breathing, right? So what type of breathing is it called? It's called Kussmaul's breathing. It's called Kussmaul's breathing, right? The Kussmaul's breathing is the type of respiration that you have in acidosis, metabolic acidosis. So what type of acidosis do you get in DKA? What type of acidosis? It is high anion gap metabolic acidosis. High anion gap metabolic acidosis. High anion gap metabolic acidosis. So when you give the patient lot of IV fluids, you give the patient lot of NS. You give normal saline. So along with the correction of the hydration, you're also giving more chloride to the patient. You're also giving more chloride to the patient. You're giving more chloride to the patient. So the patient will have hyperchloremia. The patient will have hyperchloremia. Hyperchloremia. Okay. The patient will be having hyperchloremia. Okay. So that also you need to keep it in mind. That time you should reduce the IV fluids to half NS. Okay. You can reduce the fluids to half NS. So high anion gap metabolic acidosis, and later the patient can develop hyperchloremia. So that's why you should keep monitoring the electrolytes very, very frequently. And there's also high risk for hypokalemia because we're giving an insulin infusion. Okay. These are few points. Okay. Then what is the best test to diagnose? What is the best test to diagnose DKA? You have to check the beta hydroxy butyrate levels. Beta hydroxy butyrate levels. So what is the best test to diagnose DKA? You have to check the beta hydroxy butyrate levels. Okay. So in these patients, when you're having high sugars, one thing that you must remember is the patient can have a pseudo hyponatremia. So I told you why you have to check the electrolytes. One is because the patient can develop hypokalemia because you're giving insulin, right? Hypokalemia. The chloride can increase because of giving IV fluids. There can also be pseudo hyponatremia because of the high sugars, right? The patient can also have pseudo hyponatremia because of the high sugars. And obviously, because of metabolic acidosis, the bicarbonate will be less. Okay, so all these electrolyte abnormalities are very, very common. So you need to constantly check the electrolytes frequently, say around every 4 hours once. You need to check this. Okay, so one more thing that they will be asking you, which is a very common question, is how do you differentiate between hyperglycemic hyperosmolar coma and versus DKE? How do you differentiate? So obviously, you know, in this patients, the ketones will not be positive. So ketones will be negative, but here it will be positive. Right, the ketones will not be positive, will be negative in hyperglycemic hyperosmolar coma, and in DKA it will be positive. Mainly DKA patients, it is in type 1 diabetes mellitus, whereas hyperglycemic hyperosmotic coma will be in type 2 diabetes. Okay, and essentially the age will also be middle-aged patients, whereas in DKA it usually be a younger one. And this hyperglycemic HHC is not very common; it is quite rare. Commonly we encounter DKA only. That is because in HHC, there is no absolute reduction of the glucose, the insulin levels. There is a relative deficiency of insulin, right? There is a relative deficiency of insulin. There is a relative deficiency of insulin in the patient, but in this DKA, there will be an absolute deficiency of insulin. So that's why you develop this different findings, okay? And this hyperglycemic hyperosmolar coma will develop over days to weeks. But however, this DKA will be very acute. Within few hours, the patient will be developing. Okay, this will be developing within few hours. This has high mortality. However, DKA, if you correct properly, then you will be actually saving the patient, right? So these are the key differences between hyperglycemic hyperosmotic coma and DKA. Okay, this is again a very, very important question. You must be all be aware of that, right? Yes, Dr. Strength. So its ketone bodies will be negative in HHC. Okay, yes. So I hope this is a very detailed discussion of DKA. Definitely there is a question on DKA every year. So ABG, DKA, these are all very important topics that you must remember. Okay. So the following are features of Weber syndrome except contralateral hemiplegia, ipsilateral oculomotor nerve palsy, contralateral involuntary movements, ipsilateral paralysis of face. So when it comes to these syndromes, we often get confused between ipsilateral, contralateral, and we also don't know what are the regions which are involved, right? So that's why these questions become tough. So once you learn the neuroanatomy easily, so this will also be very easy for you to answer. Okay, so Weber syndrome, what is it? It's a midbrain syndrome, right? So it's a midbrain syndrome. Any of you can answer this question. It is what are the following features of Weber syndrome except contralateral hemiplegia, ipsilateral oculomotor nerve palsy, contralateral involuntary movements, or ipsilateral paralysis of face. Okay, so any of you can try answering this question. We'll discuss parallelly. So what are we discussing? We are discussing a midbrain syndrome. Okay, so we are discussing a midbrain syndrome. So what happens? Here you have the third nerve nucleus, right? You have the third nerve nucleus. You have the medial longitudinal fasciculus, third nerve nucleus, and the medial longitudinal fasciculus. So other thing you have is substantia nigra. This is substantia nigra. And here you have the crus cerebri, right? Here you have the crus cerebri. I'm telling the important ones that you need to remember for Weber syndrome. Okay, so this is the crus cerebri that you will be having, and you will be having a substantia nigra. You'll have the medial longitudinal fasciculus and the third nerve, right? Apart from that, you'll also be having the red nucleus here. You'll also be having the red nucleus there. Okay, so what happens is, here you will also be having the spinothalamic tract, lateral spinothalamic tract, lateral spinothalamic tract. So these are the important tracts which you find in midbrain. Here you will have the superior colliculus, right? Superior colliculus. So among the midbrain syndromes, the most important one and frequently asked one will be Weber syndrome, right? So you will be having a crossed hemiplegia. That's right. You will be having a crossed hemiplegia. Yes. Good guessing. The answer will be, we'll discuss the answer. So first is Weber syndrome. So where does Weber syndrome get affected? The Weber syndrome is usually happening around this area, right? So this area will be affected in Weber syndrome, right? This area will be affected in Weber syndrome. So what are the parts which are getting affected? Here you have the crus cerebri. So once the crus cerebri is affected, you have contralateral hemiplegia, right? You have contralateral hemiplegia, right? Contralateral hemiplegia will be there. Then the nucleus fibers from the third nerve are also getting affected. So you have a, what do you have when you have the third nerve affected? Ipsilateral third nerve palsy. Ipsilateral third nerve palsy. Also, you find that some part of substantia nigra is also getting affected. Substantia nigra is also getting affected. So you will have contralateral tremors. Contralateral involuntary movements, especially tremors. So in this question, when you see, the patient is having a contralateral hemiplegia. The patient is also having an ipsilateral oculomotor palsy, ipsilateral third nerve palsy, and contralateral involuntary movements. But the answer for this question is, what is not found in Weber syndrome? That will be ipsilateral paralysis of lower face, right? There is no work for the lower face fibers to be here. So it is a midbrain syndrome basically. So there is ipsilateral lower paralysis of lower face, which is not there. So in Weber syndrome, you have a contralateral hemiplegia, which all of you will remember definitely. The other point you'll also remember is an ipsilateral oculomotor nerve palsy. The thing that you must remember is the contralateral involuntary movements can also be present. Okay, I hope it's a good learning point for you. Contralateral involuntary movements will also be present. Okay, that is Weber syndrome. So there is one more which will be affected. That is when the red nucleus is affected, you call it a. So when the red nucleus is affected, what do we call it? We call it a Benedict syndrome. What do we call it? We call it a Benedict syndrome. Benedict syndrome. In this, what happens? You will have this region will get affected, right? So this region will get affected. So you will have an ipsilateral third nerve palsy, ipsilateral third nerve palsy. Along with that, you will have contralateral chorea and resting tremors. Chorea or resting tremors, right? So this is when the red nucleus is getting affected. Okay. So other things that you must remember is the Claude syndrome and the Benedict syndrome, right? Claude syndrome, Benedict syndrome, and the Weber syndrome. These are all very important in midbrain. Okay. Yes. So the answer to this question will be, this will be the answer. Ipsilateral lower paralysis of face will not be there. Okay. Yes. So the following are the features of Brown-Sequard syndrome except contralateral loss of joint position and sense, contralateral loss of pain, ipsilateral element lesion at the level of lesion, and contralateral motor functions are lost. Okay. So what are not the features of Brown syndrome, Brown-Sequard syndrome? So Brown-Sequard syndrome is essentially a spinal cord hemisection, right? Spinal cord hemisection. So you have a spinal cord and half of it is gone. Okay. So that's what we are going to discuss. Okay. Any of you can answer this question. So the following are not features of Brown-Sequard syndrome except contralateral joint loss of joint sense and position, contralateral loss of pain, ipsilateral element lesion at the level of lesion, and contralateral motor functions are lost. Okay. Yeah. So let us see what the spinal cord has. So you have a spinal cord here, right? You have a spinal cord, you have the aqueduct, and then you have the, sorry, I'll just draw it again. Now the aqueduct. Yes, so just some beautification. Okay, so what happens? This part will be lost. So this entire half is lost. Isn't it? This entire half is lost for this patient. So what are the columns that we have in these patients? So first here you have the dorsal column, right? Dorsal column. We all know what the dorsal column carries. It carries proprioception, fine touch, vibration sense. All these are carried by the dorsal column, right? That is dorsal column. Then you have the descending sympathetic chain. Sympathetic chain. Okay, this is the descending sympathetic chain that will be there. And you will also have the corticospinal tract here. What will be having? Corticospinal tract. You have the corticospinal tract and the descending sympathetic fibers. So autonomic fibers will be there. Autonomic fibers here, and the autonomic fibers here and the corticospinal tract. And what will you be having here? You will be having the anterior and lateral spinothalamic tract. Anterior and lateral spinothalamic tract. So when these are affected, based on that, we are going to find out the findings. So when the dorsal column is affected, what you have? You have ipsilateral loss of fine touch, proprioception, and vibration. Proprioception and vibration, right? You have loss of ipsilateral, fine touch, proprioception, and vibration, right? So once the corticospinal tracts are affected, what happens? It is an UMN lesion, right? It is an UMN lesion. So it's an UMN lesion. Below the level of lesion, you will have a UMN lesion, UMN spastic paralysis. Spastic paralysis below the level of lesion. UMN spastic paralysis below the level of lesion. So here, one more thing that you will be having is what are these? These are the anterior horn cells, right? What are these? These are the anterior horn cells. So here you can see this will also be getting affected. So when the anterior horn cells are getting affected, you will be having an LMN lesion at the level of lesion. LMN lesion at the level of lesion. Okay. So you will be having a human paralysis below the level of lesion, but at the level of lesion, you will be having an LMN paralysis. Okay. So once the spinothalamic tract is getting affected, what will you be having? What will you be having? You will be having spinothalamic tract, you will be having contralateral loss of pain and temperature. Contralateral loss of pain and temperature. So why do I say contralateral for this? Why do I say contralateral for this? And the others I'm saying ipsilateral. Why is it so? It's because you have a spinal cord, right? You have a spinal cord. The pain and temperature fibers are coming. So what does it do? It comes and it ascends around 2 to 3 levels. It ascends around 2 to 3 levels. And then it crosses over to the opposite side and then ascends as the spinothalamic tract. So essentially, when you lose a sensation, it happens just 2-3 levels below the level of lesion. Suppose you have a section here, which is, there's a hemisection this side, right? In this level of lesion, what happens is, what is perceived is, the loss will be perceived below 2 levels, right? Suppose this is, say L3, say this is T3, okay? So the level of this one will be T4 and T5. So if there is a lesion at T3, you will be perceiving the loss in the lesion of level of T5. Only for the spinothalamic tract. So that's why for this I say it's contralateral. It is going up, it is crossing over after 2 or 3 levels only. So that's why I'm saying it's a contralateral loss of pain and temperature. Right? And the level of lesion will be 2 levels below for you to perceive that lesion. Okay. So I hope this is clear. When you have a Brown-Sequard syndrome, which is a hemisection of the spinal cord, you will have a dorsal column involvement causing loss of ipsilateral fine touch, pain and proprioception, vibration, and the autonomic fibers will be lost. So you will be having autonomic lesions, and you'll also be having human paralysis, spastic paralysis below the level of lesion. At the level of lesion, you will be having an LMN lesion, and spinothalamic tract is getting affected. So you will have a contralateral loss of pain and temperature. Okay, so let's go to this question. So you will be having contralateral loss of joint position, joint sense and position. No, that will be ipsilateral. Contralateral loss of pain will be there. You'll have ipsilateral LMN lesion at the level of lesion, and you will also have contralateral motor functions, contralateral motor functions. It will be ipsilateral motor functions which will be lost. Okay. Yes. So let's move on to the next question. A 30-year-old gentleman is found to have a mid-systolic murmur, heard best in the left sternal border. It is found to increase on standing. What is the likely diagnosis? Right? What is the likely diagnosis? What is the likely diagnosis for this patient? Is it mitral regurgitation, mitral stenosis, ventricular septal defect, or hypertrophic obstructive cardiomyopathy? So 30-year-old gentleman is found to have mid-systolic murmur, heart best in the left sternal border. It is increasing on standing. So what is the likely diagnosis? Right? So yes, we'll discuss. So dynamic auscultation is very, very important. They catch you on this, and it's quite easy if you understand the concept behind it, isn't it? So dynamic auscultation is a very important point of auscultation, especially in your final year exams. You will be asked to tell what happens to the findings. Okay, so you need to find out the answer. So just put the options again. A 30-year-old man is having a mid-systolic murmur, which is heard best in the left sternal border. The options are mitral regurgitation, mitral stenosis, ventricular septal defect, and hypertrophic cardiomyopathy. So mitral stenosis is right away, eliminated because it's a mid-systolic murmur. It's not a mid-diastolic murmur, it's a mid-systolic murmur. So this is taken away. Okay, so let's find out what happens in the dynamic auscultation. Okay, so first we have HOCM, we have aortic stenosis and mitral valve prolapse, right? HOCM, aortic stenosis and mitral valve prolapse. So on inspiration and expiration, there will not be much change, because the inspiration, what happens is the right side murmurs will increase and the left side murmurs will increase on expiration. Like this, we all know it's a common rule. Left sided murmurs will increase on expiration and the right side murmurs will increase on inspiration. Right? With this, all of us know. Okay, so let's talk about Valsalva maneuver. Valsalva maneuver, following which the patient is standing abruptly or standing abruptly. If the patient is standing abruptly, what happens? The preload will be reduced. Okay, the preload will be falling down as all of a sudden. So once the preload reduces, what will happen? The HOCM murmur will increase. The HOCM murmur will increase. Also the MVP murmur. But the aortic stenosis murmur will decrease. HOCM murmur and the MVP murmur will be increasing, whereas aortic stenosis murmur will be falling down because of the drop in the preload. Okay, because of the drop in the preload, because the venous return reduces. Okay, once you stand abruptly, the venous return drops because there is a lot of pooling in the peripheral blood vessels. Okay, so the HOCM murmur will increase, the MVP murmur will also increase in intensity, but the aortic stenosis murmur will reduce. Okay, yes. So the next one will be squatting. Squatting plus passive leg raise. What happens when you squat or you have a passive leg raise? What happens in these conditions? The afterload is increasing, right? What happens when you passively raise the thing? The preload will raise. So the preload will be increasing. Once the preload increases, the HOCM murmur will decrease. But the aortic stenosis murmur will increase and the MVP murmur will be decreasing. So this is very clear, you have to understand. Okay. So once the preload, I'll tell you, this is a condition in which the preload will be reducing. When the preload reduces, the HOCM murmur and the MVP murmur will increase. Whereas when the preload is reducing and the preload will be increasing, what will happen is the HOCM and the MVP murmur will decrease. And it is the opposite for aortic stenosis, which you must remember. Okay? Yes. So this will be easy to answer now. Okay? So this patient is having an increasing on standing. So the patient will be having an hypertrophic obstructive cardiomyopathy. Right? Hypertrophic obstructive cardiomyopathy. One more thing, echocardiographic finding that you must remember, which is asked in the MCQs, that is SAM, the systolic anterior motion of the mitral leaflet. Systolic anterior motion of the mitral leaflet. Shall I write it down for you? Systolic motion, anterior motion of the mitral leaflet. Right? Yes. Yes, Dr. Strength, it's correct. Because of the decrease in the preload. That's correct. Okay? Yeah. So let's move on to the next question. Which of the following is more common in limited cutaneous systemic sclerosis when compared to diffuse cutaneous systemic sclerosis? Is it esophageal dysmotility? Is it myopathy? Is it interstitial lung disease? Or is it scleroderma renal crisis? Okay. So scleroderma, Sjogren's, all these are asked very frequently. So when they talk about Sjogren's, most commonly they ask about distal RTA, which is that is what is associated with that. So they ask questions based on that. But when it comes to systemic sclerosis, they ask about Raynaud's phenomenon. They can ask you about the limited versus the diffuse systemic sclerosis. All these things are asked very frequently. Again, what are the antibodies involved? Okay, so this is what we are going to learn in this. So if none of you can answer this question, I'll be happy. So is it which is more common in limited cutaneous systemic sclerosis as compared to diffuse cutaneous? Is it esophageal dysmotility? Is it myopathy? Is it ILD? Or is it scleroderma renal crisis? Which one of the answers? Yeah. Okay. So we'll go to the discussion. So scleroderma It is more common among the females. All of us know it is more common among the females, right? In the ratio of 5:1. It is more common. So what do you have basically? You have thickening and induration, right? You have basically thickening and induration. Thickening and induration. What is the most important symptom in these patients? It is Raynaud's phenomenon. So what is Raynaud's phenomenon? What is Raynaud's phenomenon? So when the patient is exposed to cold atmosphere, what will happen is the patient will have severe pallor of the extremities. There will be severe pallor followed by cyanosis, and when there is rewarming, there will be severe redness and pain. Okay, so this is a very painful condition. The patient will be having, first there will be pallor on exposure to cold, there will be pallor. After that, the patient will be having cyanosis, and when it is being rewarmed, there will be severe redness and pain. Redness and pain on rewarming. That is a characteristic finding of Raynaud's phenomenon. This is a characteristic symptom, right? And one more thing that you must remember, what is the most common complication of systemic sclerosis? It is pulmonary artery hypertension. Okay, pulmonary artery hypertension is the most common complication. So now coming to the classification. So what is the classification? It's either diffuse or limited. So diffuse or limited. So when we talk about limited, you have a CREST syndrome, right? CREST syndrome, this is very commonly asked in the MCQs. So this you must remember. What are the findings? What is this CREST syndrome? What does it mean? C is for calcinosis cutis. Calcinosis cutis. R is for Raynaud's phenomenon. Raynaud's phenomenon. E is for esophagitis. Esophagitis. Then S is for sclerodactyly. S is for sclerodactyly and T is for telangiectasia. Right, telangiectasia. This CREST syndrome you must remember because they ask very commonly these questions. Okay, calcinosis cutis for C, Raynaud's phenomenon, esophagitis, sclerodactyly, and telangiectasia. Right. So, what is the antibody involved in this limited variety? It is anti-centromere antibody. Anti-centromere antibody. Whereas in diffuse it will be anti-SCL70 or anti-topoisomerase 1 antibody. It's either anti-SCL70 antibody or anti-topoisomerase 1 antibody. Right. So what happens in this diffuse? It is a mild condition. It is not very severe. Whereas this limited will be very severe and very painful. Severe and painful. Right. This patient will be having a critical limb ischemia very often. The patient will be having a critical limb ischemia very often. Okay. So this is what you need to remember. The basic differences are, the important findings are, the antibodies in diffuse variety you have anti-SCL70 or anti-topoisomerase 1 antibody, whereas in limited variety you have the anti-centromere antibody. Okay, and you have to remember the CREST syndrome, which is calcinosis cutis, Raynaud's phenomenon, esophagitis, sclerodactyly, and telangiectasia. Okay, yes. So esophageal dysmotility. Okay, so the answer for this question is esophageal dysmotility. That's right, because you've seen it is more common in this CREST syndrome, esophageal dysmotility. So esophageal dysmotility is the answer for this question. So one thing about scleroderma renal crisis. So what happens in this patient? The patient will having a very high BP, sudden BP elevation along with an AKI, sudden BP elevation along with an AKI, and the patient will also be having microangiopathic hemolytic anemia, right? Microangiopathic hemolytic anemia. The BP will become so high that you will be having findings on the fundus also. And there will be hypertensive hemorrhages also, which can be happening. So this is scleroderma renal crisis. Right? Interstitial lung disease, all of us know it's very common in systemic sclerosis. Most common complication will be pulmonary artery hypertension and interstitial lung disease. Okay? Yeah. So esophageal dysmotility is more common in limited cutaneous systemic sclerosis when compared to diffuse cutaneous systemic sclerosis. Right? Yes. So let's move on to the next question. Which of the following is the type of aphasia seen in the lesions of the posterior part of superior temporal gyrus? Okay. The question is a bit twisted. So you have to find out whether it is a Broca's aphasia or a Wernicke's aphasia or what are the other kinds of aphasia that you must find out. Okay. Posterior part of superior temporal gyrus. It's actually an easier question, but it's just they're playing with the words. So is it a non-fluent aphasia? Is it a fluent aphasia, anomic aphasia, or conduction aphasia? Right? Yes. Any one of you can answer this question? It's just a play of words. It's very straightforward question actually. Yeah. So before we go on to that, we'll see what is the. So one of you can answer this question. I'll just put up the question again. What is the type of aphasia in the lesions of the posterior part of superior temporal gyrus? Is it a non-fluent aphasia? Is it a fluent aphasia, anomic aphasia, or a conduction aphasia? Okay, yeah. So let's see the Brodmann areas, which is very easy. Broca's area, two areas which are mainly involved in speech, which is the Broca's area and the Wernicke's area, right? Broca's area and the Wernicke's area. So Broca's area is mainly for the articulation and the motor component of the speech, whereas Wernicke's is for the sensory component, like the comprehension, understanding. All this is for the Wernicke's area, right? What are the Brodmann areas? Brodmann areas are 44 and 45. This will be area 22, right? Whereas the lesion, this will be in the posterior inferior frontal gyrus, right? Posterior, it's in the frontal region, inferior frontal gyrus. Whereas this will be in the superior temporal gyrus, in the posterior part, superior temporal gyrus. Superior temporal gyrus. So we already have the answer to this question, right? It's in the superior temporal gyrus. So both these are present in the dominant lobes. Right? Both these are present in the dominant lobes. So Broca's area, it will be 44, 45 in the posterior inferior frontal gyrus. And Wernicke's area is in the area 22. It is called area 22. It is present in the superior temporal gyrus. Okay, so let's see how do we approach aphasia. Okay, so let's say this patient is having aphasia. So what are the points that you must consider? What is the first thing that you will consider in this patient? You need to check whether the patient is fluent. So you have to see fluency. You have to check for fluency. You have to check for fluency. So we'll check for fluency. We'll see whether the patient is fluent or not. No, yes, right. The patient is having fluency or not. So once we know this, you have to check whether the comprehension. How is the comprehension for this patient? Is the patient able to comprehend or not? Right? Based on that, you will say no, yes. We'll just write it and then I'll explain to you. So this is no. And again, you don't have comprehension, you have comprehension. Right? After this, what is the other point you'll be checking? You'll be looking for repetition. You will be looking for repetition. Right? You'll be looking for repetition. So we'll see again whether this is yes or no. No, yes. Again, this will be no, and this will be yes. No, yes. Okay. So let's see. The patient is having a fluent aphasia. The patient is not having any fluency. So the patient is not having fluency and there is no comprehension and there is no repetition. So none of it is present. So the patient means the patient is having global aphasia, right? The patient is not able to have fluent speech. The patient is not able to have comprehension. There is no repetition. Nothing is there. So the patient is having a global aphasia, right? So the patient is having a fluency. The patient is also having comprehension, but the patient is also having repetition. But he is aphasic. So what does it mean? The patient is not able to name the objects. So that is called anomic aphasia. So these are the ends of the spectrum. This is anomic aphasia, right? It's global aphasia on one end and it's anomic aphasia on the other end. So all the rest comes in between, right? So let's see. When the patient is having fluency, comprehension, when the patient is not having fluency, not having comprehension, but repetition is there, then that means that the patient is having a mixed transcortical aphasia. Mixed transcortical aphasia. Okay, mixed transcortical aphasia. So the patient is having fluency. The patient is not having fluency. The patient is not having comprehension. The patient is having comprehension, but is not able to repeat. So what? No fluency, no repetition, but he is able to comprehend. So what does this mean? The patient is having a Broca's aphasia. The patient is having a Broca's aphasia. He is able to comprehend, but he's not fluent or he's not having any repetition. So this is Broca's aphasia or Motor's aphasia. He's able to comprehend. Okay. The patient is not having fluency. The patient is having fluency. He is not able to comprehend, but there is no repetition also. So what does this mean? There is no repetition, there is no comprehension. Because he's not able to comprehend, he's not able to repeat. But the fluency is there. He's just going on talking continuously. So what does this mean? This means that the patient is having a Wernicke's aphasia. Wernicke's aphasia. Right? The patient is having a Wernicke's aphasia. Okay. The patient is very fluent. He's able to talk continuously, but he's not able to comprehend or repeat whatever you say. So that is Wernicke's aphasia. So when the repetition is intact in a similar kind of Broca's aphasia, that will be transcortical motor. Right? That will be transcortical motor. Transcortical motor aphasia. And this will be transcortical sensory aphasia. One more thing that you must be remembering is the patient is fluent. The patient is also having comprehension, but there is no repetition. That means that the patient is having conduction aphasia. Conduction aphasia. So what do we mean by conduction aphasia? There is a problem in between the centers which are connecting the Wernicke's and the Broca's area. Okay, so there is a conduction aphasia. So I hope this answers this question. So the patient is having a superior temporal gyrus lesion. So what does it mean? The patient is having a lesion in the Wernicke's area. So when the Wernicke's area is affected, what did I say? The patient will not be able to comprehend. He will not be able to repeat, but he'll be able to, talk fluently. So he's having a fluent aphasia. Okay, fluent aphasia will be there, but the patient is not able to comprehend or understand whatever you're saying. Right? Yes. Let's move on to the next question. A 16-year-old girl is brought to the OPD with complaints of fatigue, chronic diarrhea, weight loss, bone pain, and abdominal distension. On investigation, iron deficiency anemia is there and osteoporosis also noted. Which of the following is the best test to identify the diagnosis? Right? So there is a patient with a malabsorption syndrome, right? There's fatigue, chronic diarrhea, weight loss, bone pain, and abdominal distension. There's anemia and osteoporosis also. So what is the best test to identify the diagnosis? Right? So this is basically a malabsorption syndrome. So malabsorption syndrome, especially about celiac sprue, is very, very commonly asked in the exams. Celiac sprue. So when we talk about GAT, celiac sprue is asked, IBD will be asked, and the UGA bleeds. These are the three most important topics that you must be touching upon in GI tract with regards to medicine. Okay, so let's see about malabsorption syndromes. So in malabsorption syndrome, what are the basic three problems? There is problem in digestion. So there could be a problem in the digestion, or there could be a mucosal abnormality which is present. There could be a mucosal abnormality, or there is a absorption which is present. Absorption will be defective. Right, there is an absorption which is defective. Either the digestion could be a problem, or the epithelium could be a problem, or the absorption could be a problem. These are the three problems which can be noted in a patient who is having a malabsorption presentation. Right, so any of you can answer this question? Okay, so these are the three problems which are there. So among that, celiac sprue falls under this mucosal issue. So what happens in the celiac sprue? Celiac sprue. What is it otherwise called? It is also called gluten-sensitive enteropathy, right? The patient is sensitive to gluten. It's called gluten-sensitive enteropathy. So I think now you must be knowing the answer. You should be measuring the tissue transglutaminase levels of antibody levels, right? So that is the answer for this question, but we'll discuss something about celiac sprue. So gluten-sensitive enteropathy it is an immune-mediated inflammation, right? It's an immune-mediated inflammation. So what it is characterized by? It is characterized by two things. One will be crypt hyperplasia. Crypt hyperplasia. So the patient will be having crypt hyperplasia and also villus atrophy. Okay, villus atrophy and crypt hyperplasia will be present. So the patient will be having crypt hyperplasia and villus atrophy, right? These two will be present. So these are the characteristic findings which are commonly asked in the MCQs. So the patient will be having a crypt hyperplasia and a villus atrophy. Okay, so what is the antibody that you'll be measuring in this patient? Anti-tissue transglutaminase, right? Anti-tissue transglutaminase antibody. This is a TTG antibody. Okay, this is the antibody which will be measuring in these patients. Anti-tissue transglutaminase antibody. Okay. Yes. So this will be the answer to this question. So how do they present? They'll be having chronic diarrhea, chronic weight loss. They'll be failure to thrive if it presents early. Okay, they can have other associated GI problems also. They will have a constant bloating sensation. There will be irregular bowel habits. There will be vitamin D deficiency, which causes osteoporosis. Okay, and severe anemia will be there because B12 and iron don't get absorbed properly. Okay, so this will be the antibody which will be testing. So one more antibody can be present, which is called anti-endomysial antibody. What is the antibody? That is anti-endomysial antibody. This also can be positive in these patients. So what is the gold standard test for these patients? It will be a biopsy. Like I told you, what is the biopsy finding? You will have a crypt hyperplasia and villus atrophy. You will be having a crypt hyperplasia and a villus atrophy in these patients. Okay, so what are the other malabsorption syndromes that you must be remembering? You'll be having tropical sprue, you can have A beta lipoproteinemia or lactose intolerance. These are also very, very important malabsorption syndromes. Okay, yes. So let's go on to the next question. A 30-year-old male was brought to the hospital with complaints of excessive fatigability towards the end of the day, which is improved on resting. He also complains of drooping of eyelids and difficulty in swallowing. So what is the most likely diagnosis? Is the patient having myasthenia gravis, Lambert-Eaton syndrome, Duchenne muscular dystrophy, or SLE? Okay, so 30-year-old male is presenting with excessive fatigability towards the end of the day, which is improved with resting, drooping of eyelids and difficulty in swallowing. So what is the diagnosis? So one of you can answer this question. What is the answer for this question? So it's not Duchenne muscular dystrophy because it usually presents in childhood. And by the time he's 30 years old, he must be severely disabled. He must be in a wheelchair, or the life expectancy is also not that great. Right? So it's not Duchenne muscular dystrophy. If it was systemic lupus erythematosus, the main presenting feature will be a joint pain, rash, and all those things which they have not mentioned in this question. They're basically talking about a muscular or a neuromuscular junction disorder. Right? So it can be either myasthenia gravis or a Lambert-Eaton syndrome. Right? So there are few points which you must remember. This is very high yielding. Once you know these points, you can answer these questions very easily, isn't it? So what are the differences between myasthenia gravis and Lambert-Eaton syndrome? Lambert-Eaton syndrome. So first of all, this is a postsynaptic defect, right? Postsynaptic. And this is a presynaptic defect. So what do you mean by that? So postsynaptic, in this acetylcholine is there in enough quantities, right? But the acetylcholine receptors are not effective in accepting these acetylcholine, which is released from the neuromuscular junction on the other side, from the presynaptic side. Okay, so in Lambert-Eaton syndrome, what happens? It's a presynaptic defect. It is against a voltage channel, voltage-gated calcium channel defect. Voltage-gated calcium channel defect. Calcium channel defect. So what is the antibody which is present here? It is anti-PYQ antibody. What is antibody? It is anti-PYQ antibody. In this, what you have? You have anti-acetylcholine receptor antibody. Acetylcholine receptor antibody. What are other antibodies implicated in myasthenia gravis, which is a very, very important MCQ question? Anti-MuSK antibodies. Anti-MuSK antibodies. Muscle-specific kinase antibodies, anti-MuSK antibodies, or anti-LRP4 antibody. Right? Anti-LRP4 antibody. So myasthenia gravis, you need to remember these three antibodies, whereas in this Lambert-Eaton syndrome, you need to remember just one antibody, anti-PYQ antibody. This is a postsynaptic defect. This is a presynaptic defect. Okay. So what happens in myasthenia gravis is when the patient is exerting through the end of the day, he becomes very tired. So the muscles are also very fatigued. Okay. So what happens? The weakness worsens with exercise. Worsens with exercise. Whereas here the weakness will be becoming worse with rest. Okay. So basically this myasthenia gravis, the weakness will be worsening with exercise. Okay. When you start exercising the patient more, then the patient will become worse. The weakness will become more. Isn't it? Okay. So one more important thing that you must be remembering is there will be a decremental response. You keep on stimulating the nerve again and again. So a lot of acetylcholine is released, but the acetylcholine receptors have not accepted it. So the muscle, when it gets stimulated, when the nerve gets stimulated and it's activating the muscle, there will be a decremental response. First, it will react nicely, but once the acetylcholine receptors are all occupied and it is lesser in number, so they will not give appropriate response. So what happens? You will have a decremental response. Decremental response on repeated nerve stimulation. Decremental response with repetitive nerve stimulation. Okay, on repetitive nerve stimulation. Whereas in this, you will have an incremental response. You will have an incremental response. Right? You will have an incremental response. So, one more important thing that you must remember is there are no autonomic involvement in myasthenia gravis. It will not be there. But here, in Lambert-Eaton syndrome, you will definitely have a autonomic involvement. So where do you come when the question talks about Lambert-Eaton syndrome? What will be the presentation of that patient? It will usually say that the patient is having a patient is having a small cell lung cancer or oat cell cancer, and this patient is developing this weakness and all these features. So it is most commonly developing as a paraneoplastic syndrome. It is most commonly developing as a paraneoplastic syndrome, right? When you talk about myasthenia gravis, it can mention about thymoma. Though not commonly mentioned, this can be the presentation. They can mention that the patient is having a thymoma, or the patient is having other autoimmune disorders along with that. So the patient could be having Graves' disease, and along with that, the patient could be having myasthenia gravis. The patient could be having vitiligo. He can also develop myasthenia gravis. So once the patient has developed a autoimmune disease, he can develop other autoimmune diseases also, isn't it? So thymoma can be associated with myasthenia gravis, whereas Lambert-Eaton syndrome is most often represented like a paraneoplastic syndrome. Okay, so these are the very important things that you must remember. So what are the key points? No, it's a postsynaptic. This is a presynaptic one. The antibody is acetylcholine receptor antibody. It is anti-PYQ antibody. This myasthenia gravis worsens with exercise. There is a decremental response, whereas here you have an incremental response, and there is no autonomic involvement in these patients with myasthenia gravis. Whereas in Lambert-Eaton syndrome, you have this autonomic involvement. Okay, these are the important things. So one more thing that you must be remembering is, what is the investigation of choice for myasthenia gravis? What is the investigation of choice? It is single fiber electromyography. Single fiber electromyography, right? And what is the drug of choice? It is pyridostigmine. Pyridostigmine. Pyridostigmine is the drug of choice. So when the patient is having a myasthenic crisis like a respiratory failure, and the patient is intubated, what will you treat the patient? You either have to give IVIG, or you have to do plasmapheresis. You have to do plasmapheresis. Right? You have to do either IVIG or plasmapheresis when the patient is in myasthenic crisis. When the patient is having respiratory failure, severe myasthenia, that time you have to do either plasmapheresis or IVIG to take out the antibodies. Okay, so the answer to this question is, the patient is having excessive fatigability towards the end of the day, which is improved with resting. Drooping of eyelid ptosis was there, and difficulty in swallowing. There is no mention about any autonomic involvement, and it's a male. Just to confuse you, it is more common in females, but males also do present with myasthenia gravis. It's just a point of confusion. So this answer will be myasthenia gravis. So the answer to this question will be myasthenia gravis. Okay, yes. So let's move on to the next question. A 40-year-old male presents to you with complaints of fever, night sweats, ptosis, and bilateral facial nerve palsy. Purplish painful nodules are seen on his extremities. Investigations showed leukocytosis and bilateral hilar lymphadenopathy. What is the most likely diagnosis? So what is this patient presenting with? Is it sarcoidosis, tuberculosis, lymphoma, or hypersensitivity pneumonitis? Okay, can any of you answer this question? Is it sarcoidosis, tuberculosis, lymphoma, or hypersensitivity pneumonitis? So what is the answer to this question? Yeah. So the answer to this question will be sarcoidosis, right? The answer to this question will be sarcoidosis. So you have a patient presenting with fever, night sweats, ptosis, and bilateral facial nerve palsy. There are very few conditions will present with bilateral facial nerve palsy. Okay. So one of that is sarcoidosis. So bilateral hilar lymphadenopathy, all of us know, it immediately strikes sarcoidosis for us. So what about sarcoidosis? What is it? It is a granulomatous disorder, non-caseating granuloma. So it is a granulomatous disorder. Granulomatous disorder. So how will the patient present? The patient will be having fever, cough, night sweats. The patient will be having hypercalcemia. This is very, very important. Commonly, the question can also, I have told you the clinical features, but in some cases, the patient can be showing features of hypercalcemia, moans, groans, and other things. So the patient will be presenting with hypercalcemia. Okay. The patient can have uveitis. The patient can have uveitis. Red eyes will be there. So the patient can have uveitis. The patient can also have bilateral seventh nerve palsy. Okay. The other condition where you can have a bilateral seventh nerve palsy is multiple sclerosis. Okay. So the patient can have bilateral seventh nerve palsy. Okay. What else? What are the things that the patient can have? The patient can have renal manifestations. The patient can have renal manifestation. Okay. Other thing is the patient can have skin manifestations. So I have mentioned something here. Purplish painful nodules are seen. What is this called? This is called erythema nodosum. Right? Erythema nodosum. Erythema nodosum. The other thing which is characteristic of sarcoidosis is lupus pernio. So when you hear of lupus, it should not be a lupus pernio. It should not be that it should be about SLE. It is about sarcoidosis. So sarcoidosis presents with lupus pernio. Okay, this is the dermatological involvement that you see in these patients. So how do you diagnose these patients? You have to do the angiotensin converting enzyme levels. ACE levels, serum ACE levels will be elevated in these patients. Angiotensin converting enzyme levels will be elevated. The vitamin D levels also can be elevated because the granulomas will be producing vitamin D. That's why you have a hypercalcemia. Okay. And on the X-ray, you will have a bilateral hilar. And radiologically, you will have bilateral hilar lymphadenopathy. I have mentioned the question. Right, it's already mentioned in the question. Bilateral hilar lymphadenopathy will be there. On the CT chest, you have a classic finding which is called galaxy sign. It's called galaxy sign. This is again an MCQ, right? This is again an MCQ. So when we talk about sarcoidosis, two syndromes that you must remember, two named syndromes that you must remember. The first one is Lofgren syndrome. Lofgren syndrome. So what happens in this? This is a very acute presentation. The patient will have arthritis. It's usually a triad arthritis. Will have erythema nodosum. The painful lesions, all their acute findings will be the erythema nodosum. And you will also have bilateral hilar lymph nodes with anterior uveitis, with or without anterior uveitis. Okay, with or without anterior uveitis. The patient will be presenting with arthritis, erythema nodosum, bilateral hilar lymph nodes with or without anterior uveitis. This is called Lofgren syndrome. So what is the other one? Heedford Waldenstrom syndrome. Heedford Waldenstrom syndrome. Yes. In this, what you have an acute parotitis. Right? You have an acute parotitis. So the patient will be having high-grade fever. He has acute parotitis, bilateral facial nerve palsy, and also anterior uveitis. Okay, these are the important points regarding sarcoidosis that you must remember. So what all have we studied? We have to study two syndromes, Lofgren syndrome and Heedford-Waldenstrom syndrome. The diagnosis, you do it by serum AC levels which are elevated. Then you have chest X-ray findings of bilateral hilar lymph nodes and the CT chest showing galaxy sign. And you also have a hypercalcemia, which is very, very characteristic. And this is a granulomatous inflammation. Okay, and lupus pernio is not pertaining to lupus erythematosus. It is because of sarcoid. Okay, so chronic skin lesion. Right? Okay. 25-year-old lady presented to the emergency room with complaints of ingestion of multiple tablets of paracetamol and was brought within 2 hours. Gradually, she developed oliguria and deranged LFT values. Which of the following can be used in the management of this condition? Right? Is it N-acetylcysteine? Is it dopamine? Is it ursodeoxycholic acid or furosemide? So what is the answer to this question? Paracetamol poisoning. Right? Paracetamol poisoning. What are the answers? Is it N-acetylcysteine? Is it dopamine? Is it ursodeoxycholic acid or furosemide? So what is the answer to this question? So first few points that we already know about paracetamol poisoning, right? First few points that we already know about paracetamol poisoning. We know that it is hepatotoxic, right? It is hepatotoxic. So obviously the LFT will be deranged. So in the LFT, how will you find out? Bilirubin will be less. Bilirubin will be less, but the enzymes are elevated. Okay, bilirubin will be less, but the enzymes are elevated. This is one characteristic thing that you must remember. Paracetamol is hepatotoxic. The other thing is you have studied about mud piles, right? In that you have paracetamol poisoning. It is the cause of high anion gap metabolic acidosis. It causes high anion gap metabolic acidosis, right? Because it's affecting the liver, the PT-INR can also be deranged. PT can also be prolonged, right? So first what happens, the patient will be having generalized non-specific symptoms like nausea and all those things. That's what will be there. So but gradually the renal dysfunction and the hepatic dysfunction will start setting in, right? So this is what happens. Okay, so this is what happens in these patients. Okay, you have high anion gap metabolic acidosis and there is hepatotoxicity. So what should you do? You should first send out the paracetamol levels. First, you should send out the paracetamol levels and you have a nomogram based on which you should start treating the patient. So, as soon as the patient comes and you see that the patient is having symptoms, what do? You give the patient activated charcoal. And you try to bring down the load. So, activated charcoal is given for gastric lavage. Okay, activated charcoal is given and you lavage out whatever excess is left out to prevent further reabsorption. Okay. So, you give first activated charcoal. After that, you start the patient on N-acetylcysteine. N-acetylcysteine. This is very, very important. You give this to the patient, N-acetylcysteine. It can be either given orally or IV. If the patient is not able to tolerate IV, tolerate orally, then you give the patient IV. And if the levels are also serum paracetamol levels are very high, then you give the patient IV in acetylcysteine. Okay, so this should be started immediately. The benefit is more when you start the patient immediately on N-acetylcysteine. Okay, so N-acetylcysteine, there is a dosing based on the normogram. You send serial paracetamol levels and you treat the patient. Okay, so the drug of choice will be N-acetylcysteine. Okay, so you have to monitor the liver function test and also the PTINR to see how it responds to this N-acetylcysteine. Okay, yes. So the answer to this question will be N-acetylcysteine. Okay, yes. The next question, a 11-year-old child is brought with a history of sore throat and fever 5 days back. She has now developed arthralgia. There is no prior history of rheumatic heart disease. There are no features of valvular disease at present. What is the prescribed prophylaxis dosing for rheumatic heart disease? Right, what is the prescribed prophylaxis dosing for rheumatic heart disease? Is it thrice weekly lifelong? Once in 3 weeks for 5 years or till age of 18 years, whichever is longer. Once in 3 weeks for 10 years or till the age of 25 years, whichever is longer, or once in a month for 10 years. So what is the plan for treating these patients with the prophylaxis? So the patient is 11 years old now. The patient is not having any valvular disease right now. So there is no valvulitis. There is no carditis, right? There is no carditis. No carditis. Again, this is a very, very high yielding, very commonly asked in your exams. So you must remember this by heart. Okay. So let's see. If the patient is not having any the patient is having rheumatic fever, but there is no carditis. Patient is not having rheumatic fever, but no carditis. So what should you do? There should be at least 5 years. At least 5 years. Or at least till the patient is of 18 years of age, whichever is longer. Okay, rheumatic fever with no carditis, the patient should be given a prophylaxis for at least 5 years or until the patient reaches 18 years of age, whichever is longer. Okay, if the patient is having rheumatic fever with carditis but no residual damage, that means the patient should be given no residual valvular lesion. That means the patient should be given at least for 10 years or until 25 years of age, whichever is longer. The prophylaxis will become longer. Okay, if the patient is having a rheumatic fever with carditis and with rheumatic heart disease, with valvular lesions, rheumatic heart disease later, what should you do? You should give the patient lifelong prophylaxis. Lifelong prophylaxis should be given. So in this question, you see that the patient is not having any carditis, but the patient is having rheumatic fever. So in this patient, you give once in 3 weeks for 5 years till the age of 18 years, whichever is longer. So for this patient, you give it for till the patient is 18 years old. Till the patient is 18 years old, you have to give prophylaxis for this patient. So what is the drug which you give for prophylaxis? That is benzathine penicillin. Right? Drug is benzathine penicillin. This is very simple. This is benzathine penicillin. Right? 1 million units every 3 weeks. 1 million units every 3 weeks. Okay. So we know the major and minor criteria. The major criteria will be carditis, arthritis, chorea, erythema marginatum, and the subcutaneous nodules. Right? These are the 5 major criteria. And the minor criteria will be monoarthralgia, fever, increased ESR and CRP, and prolonged PR interval. So based on that, you're going to classify as high risk and low risk. And based on that, you're going to treat the patients. Right? So major criteria and minor criteria, again, like infective endocarditis in rheumatic fever, you also have to know the criteria. Right? Okay. So let's move on to the next question. A 30-year-old male is diagnosed with tuberculosis following fever since 1 month with night sweats and persistent cough. He was found to be multi-drug resistant. Which of the following drugs will not be effective in this patient? I'm sure all of you will be knowing the answer to this question, but once it's asked in an MCQ, we tend to get confused. Isn't it? What is multi-drug resistant? What is extended drug resistant? So that's what we need to be clear about. Okay, so what are the main drugs which we use? Isoniazid, rifampicin, ethambutol, and pyrazinamide. These are the 4 main drugs that we use, isn't it? So when there is drug-sensitive TB, we give induction phase for 2 months with HRZE, and after that you followed by a maintenance phase with HRE. That is the latest one, changed one, HRE. Earlier it was only H and R, isoniazid and rifampicin, but now it is HRE for 4 months. Okay, the treatment period is for 6 months. So what do we say about multi-drug resistance? Multi-drug resistance is when the patient is resistant to both isoniazid and rifampicin. Isoniazid and rifampicin. Okay, there is something called pre-extended drug resistance TB. In this, the patient is having resistance to INH plus rifampicin plus any one fluoroquinolone. This is called pre-extended drug resistance. What about extended drug resistance TB then? When do you have XDR TB? This is when you have all of these. Along with that, the patient is resistant to any of the group A drugs. So what are the group A drugs basically? You have linezolid or bedaquiline or levofloxacin. Right? If along with pre-XDR TB, the patient is having resistance to one more of the group A drugs, and it's linezolid, bedaquiline, or levofloxacin, that means the patient is having an extended drug tuberculosis, extended drug resistance tuberculosis. Okay, so these are the important things that you must remember. MDR is INH plus rifampicin. So the answer for this question will be INH plus rifampicin. So one more thing that you must remember is, with regard to tuberculosis, as an MCQ, Rasmussen's aneurysm, which artery is involved? Rasmussen aneurysm, which artery is involved? It is pulmonary artery. Pulmonary artery is involved. And the other named focus of infection that you must remember, brain will be rich focus. Just a fast revision on these. You must already be knowing all these things. Just a fast revision. Brain, rich focus. Then you will have pulmonary vein. It will be Weigard's focus. If it is a liver, you have a Simon's focus. It's called a Simon's focus. And then if it is lungs, it's called Simon's focus. It's basically an inactive one, right? It's an inactive one. If it is inactive, it's called Simon's focus. Okay? Yes. So these are the findings. Okay, so this is about a short note about tuberculosis. So let's see the next question. A 40-year-old patient presents to you with fever, jaundice, and malaise. What is the most likely diagnosis based on the serology reports given below? So the patient is having anti-HBC IgM positive, HBsAg is positive, anti-HBs is negative, anti-HCV antibodies are negative. Is it acute hepatitis B, chronic hepatitis B, acute hepatitis C, or chronic hepatitis C? So this is again a very, very high yielding question. Once you know this, you can answer so many questions. It's very important also in your clinical practice, right? So tell me, what is the answer for this question? So what is the answer to this question? So this is not hepatitis C. We are not talking about hepatitis C because we can somehow, we may get confused when we see this anti-HBC. But what is this HBC actually? It is a core antigen. Core antigen. Right, it is not hepatitis C. It is not hepatitis C virus, but it is the core antigen. This one, what we have mentioned, that is hepatitis C virus. But this HB small c is HB core antigen, right? HB core antigen. So when this is positive, we are talking about hepatitis B. So this core antigen will not be detected in the blood anytime. This will not be detected in the blood. You can only be seeing the HBC antibody. Okay, antibody can be seen. Antibody can be seen, but the core antigen will not be positive. Okay, core antigen will not be positive. Okay, so what are the other antigens that you can see? HBsAg you can see. You can also see HBsAg. You can also see HBeAg. And you can see the HB HBC antibody. Okay, it can be either IgM or IgG. These are the things that you can find out in hepatitis B. Apart from that, you can also see the hepatitis B viral load, viral DNA. You can see the hepatitis B viral DNA, right? That's what you can see. So let's see a small thing, a small graph here. So once the infection sets in, the first antigen to appear in the blood will be the hepatitis B surface antigen. Hepatitis B surface antigen. This is one will first increase, right? After that, what happens? Hepatitis E antigen will also be produced. So once the infection starts, hepatitis C starts producing antibodies. And hepatitis B core antigen starts producing the antibodies. So that core antibodies will be found. First, it will be IgM. Later, when it stabilizes, it will be IgG. That means it is a chronic infection. If IgG anti-HPC is present, that means it's a chronic infection. Right. After that, what happens to the surface antigen? You start developing antibodies. So that is anti-HBs antibody. Anti-HBs antibody. That is in the later stages. That is also again a chronic infection. Okay, so let's see. HBs antigen, HBs surface antigen, it marks infection. Again, Anti-HBe antigen, anti-HBe antigen will also mark infection. It denotes infectivity. So anti-HBs means it is immunity. So once you have given the vaccine to the patient, you will find the anti-HBs levels. If the anti-HBs levels are low, then you have to give the patient another dose of vaccine. So commonly we doctors, we get vaccinated in the UG days and then we forget about it. We have to, periodically check the anti-HBs titers and immunize ourselves if we are not having enough titers. Okay. And we also decide the post-exposure prophylaxis after needle stick injury based on this anti-HBs titers only. Okay, so this anti-HBs is very important when we are talking about vaccination and also about post-exposure prophylaxis. Okay, and the other thing is anti-HBC, you have an IgM and IgG. Okay, you can also measure the total core antibodies. Okay, IgM is during the acute phase and HBC, anti-HBC, IgG will be in the chronic phase. Okay, yeah. So, positive interpretation, we'll just see a quick recap. HBs surface antigen is positive, that means there is an infection. If the IgM is positive, anti-HBC IgM is positive, that means there is an acute infection, right? If the anti-HBC is negative, if there is a anti-HBC which is positive, HBC, the total thing is positive, then it is a chronic infection. If IgM alone is positive, then it is an acute infection. If the total is elevated, or if it is a IgM which is present, that means it is a chronic infection. If HBsAg is negative and there is anti-HBs, what does it mean? It means that we are vaccinated or that we are immune to the due to the previous infection. Okay. If anti-HBs is positive and the anti-HBC is negative, that again means due to the vaccination. If anti-HBs is negative and anti-HBC is also negative, that means we are prone to developing the infection any point of time. This is an uninfected individual so far, right? Okay. So the difference between this vaccination and this will be the anti-HBC total. This will be positive if you're already have developed the infection. I told you the immunoglobulin IgG will be elevated. So anti-HBC will be positive. But if you're only vaccinated, you have not had a previous infection, this HBC will not be positive. Anti-HBC will not be positive. So that is the difference between a previous infection and a vaccination. So this is a very high yielding question that you must remember. So the answer to this is the patient is having an acute hepatitis B. The patient is having acute hepatitis B, right? Okay. So next one is the 50-year-old male patient was brought to the emergency room with fever, headache, and confusion and seizures. MRI brain showed inflammation involving the bitemporal lobe. What is the most likely etiology for this patient? So this we are talking about a meningoencephalitis, right? So because of the next headache, fever, confusion, and seizures also developing. This bitemporal lobe, this is very characteristic of HSV. Right? How do we diagnose? PCR. PCR should be done. We should start the patient empirically on antivirals. We should not wait for the PCR report to come back and then start. So because early treatment is very, very important, you should give the patient antivirals. You should send for the HSV PCR and then you have to follow it up and treat the patient accordingly. So what happens in the cytomegalovirus, meningoencephalitis? We saw that the India ink will be positive. India ink stain will be positive in the CSF fluid, right? The patient will develop meningoencephalitis and there can also be ventriculitis. Ventriculitis is a characteristic finding. Ventriculitis can be there, right? Toxoplasmosis, you already know you will have lesions which are target-like lesions which are present in this. There will be multiple lesions present in toxoplasmosis. Herpes simplex, like I told you, temporal lobe will be involved. The limbic system will be involved. So the patient will have altered behavior. The patient will have altered behavior, right? Emotion is affected, so the patient will have altered behavior. Mycobacterium tuberculosis, there are multiple ways in which it can affect the brain. Like we all know, TB meningitis. It can also cause TB meningitis. Tuberculoma can be there. It can also cause tuberculous vasculitis. If the tuberculous exudates are, blocking the flow of the CSF into the subarachnoid space, the patient can have hydrocephalus. So there are multiple ways in which the tuberculous can affect the brain. Okay, so the answer for this question will be herpes simplex virus. Right? Okay. So the last question. The patient is brought, last but one, I think. The patient is brought to the OPD by his wife complaining about restlessness, difficulty in expressing emotions, and a fast-paced walk. On examination, the patient is having resting tremors and rigidity. So what is the likely part of the brain which is involved in this patient? So the patient is having a basal ganglia involvement, right? This is basically Parkinson's. What we have described in the question We are having difficulty in expressing emotions. That's the mask-like face. Mask-like face is right. The fast-paced walk. This is Festin gait. Characteristic Parkinsonian gait. Festin gait. Restlessness. There are tremors and rigidity. Resting tremors and rigidity. Right. So when we talk about this involuntary movements, I would just like to highlight the centers involved in the other involuntary movements. Like we saw in Parkinson's, it is basal ganglia which is involved, right? If there is chorea, where is it seen? It is seen in the caudate nucleus because of a lesion in the caudate nucleus. Chorea, caudate nucleus. What are other things we need to remember? We have to see about athetosis. We have to see about hemibalismus and dystonia, right? Yes. Athetosis, where do we see? We see in the thalamus or the corpus striatum. Thalamus or corpus striatum. This is just, you have to remember it. It's not much of understanding in this. You need to remember it, by heart, all these things. Hemibalismus, you have to think about the subthalamic nucleus. Subthalamic nucleus. You get dystonia when the globus pallidus is affected. Globus pallidus is affected. Globus pallidus is affected. When do you get these resting tremors? Parkinson's, substantia nigra. Substantia nigra is affected, you get the resting tremors. Okay, so chorea, caudate nucleus, athetosis, thalamus of the corpus striatum, hemibalismus, subthalamic nucleus, dystonia, globus pallidus, and resting tremors in substantia nigra. Okay, this is a very, very high rating again. You need to remember this. Okay. So a child presented with cola-colored urine and hypertension and puffiness of the eyes after history of fever with sore throat. The creatinine was 2.5 milligram per deciliter. And despite starting the treatment, the patient did not improve for the next 3 weeks and the creatinine has gradually increased to 4.5 milligram per deciliter. So what are the electron microscopy findings? So as soon as we see this question, what do we think? The patient is having a renal failure, right? The patient is having a renal failure, which is acute onset. So the patient could be having crescents. And the patient could be having crescent formation. So let me tell you. So this is actually the patient is having a fever and sore throat, followed by that he is developing these renal manifestations. So it's a post-infectious glomerulonephritis. Why do I say glomerulonephritis? You have hematuria, you have hypertension, right? And the creatinine elevation is there. So it's a glomerulonephritis. It is not a nephrotic syndrome because we are not mentioning about significant proteinuria, right? So this is a hypertension, hematuria, puffiness of eyes, you have edema, and also creatinine elevation. So this is basically a nephritic syndrome, right? So you have a nephritic syndrome, which is post-infectious. So in this, it is basically post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis. So what happens in these patients? You have to treat the hypertension basically, and you also have to give supportive care for the patient. You have to treat the sore throat. All these things you have to do. But when you come to the findings, what happens? It is an acute presentation. Initially, in children, we expect it to resolve completely very fast, very soon. It resolves by itself. But in some patients, it does not resolve and it progresses. Like in our case, it has progressed from 2.5 to 4.5 milligram per deciliter. Isn't it? So it has progressed. So what happens in these patients? You are having a prolonged course. So it becomes an RPGN. Rapidly proliferative glomerulonephritis, rapidly progressing glomerulonephritis. So when this RPGN happens, what happens is the characteristic finding on light microscopy will be crescents. It will be crescents, right? Crescents will be on light microscopy. One characteristic thing that you always remember when you study about PSGN is lumpy bumpy deposits, right? You study about lumpy bumpy deposits. So where do you find this basically? It is found in the electron microscopy. Which region? Subepithelial region. Subepithelial region. So in this question, what they have asked is actually an electron microscopy finding and not a light microscopy finding. So if they ask about the light microscopy finding, you would expect to find crescents. But in this question, they have asked about subepithelial deposits, the electron microscopic finding. So the answer to this question will be subepithelial deposits. Right? Okay. So the last question, a patient with previous MI and ventricular arrhythmia is on treatment since few months. He has developed fatigue, dyspnea, weight gain. He has also developed pulmonary fibrosis. Which are the following drugs cause it? So there are a few drugs that you must remember. One is amiodarone, right? That is the answer for this question. The other drugs already you will be knowing. It was bleomycin, busulfan, carmazine, and amiodarone. So what are the other adverse effects of amiodarone? you can have thyroid abnormalities, right? You can have thyroid abnormalities. So abnormality, pulmonary fibrosis can be caused by amiodarone, right? Yes. So a young patient presents with large retroperitoneal hemorrhage. He gives history of intermittent swelling of knees on strenuous exercise. There is no mucosal bleeding. What is it due to the deficiency of? Is it factor 8 and 9? Is it hemophilia? Factor 9 and 12, 11 and 12, von Willebrand factor or lupus anticoagulant? So basically this question just boils down to whether it's between this one or this one, von Willebrand factor deficiency or factor 8, factor 9 deficiency. The clinching point in this question will be that there is no mucosal bleeding. So in von Willebrand disease, what will happen is there will be mucosal bleeding, right? But this patient is not having a mucosal bleeding. So the answer to this question will be a factor 8 and 9 deficiency. Okay, so this we come to the end of this discussion. So I just try to highlight all the important topics which are frequently asked in the NEET PG questions and the associated MCQs also. We have covered so much. Actually, I would like all of you to go back and listen to it again so that you can, revise it again and again. These are all very, very high yielding questions. So I hope it's useful for all of you. I wish you all the very best in the NEET PG exams. I hope you get the seat of your choice. Thank you so much for joining. Dr. Parthiban?
Thank you so much, ma'am. Thank you so much, ma'am, for that wonderful session. It was very elaborate and very nice session. Hope all of them got very useful information out of it. Thank you, ma'am. We'll be having our next session consecutively on medicine.
Sure. Thank you so much.
For joining. Thank you.
Thank you
for joining.
Thank you, ma'am. Thank you so much, ma'am. It was really a wonderful session, ma'am. I was just listening and it was really a wonderful session. Thank you so much, ma'am.
ஆனா அப்படியே அவங்கள நசீனாக்காவை ஆட் பண்ண சொல்லி ஜாயின் பண்ண சொல்லிடுறேன் மேம்.
Okay. இந்த ஸ்ட்ரீம் எண்ட் பண்ணிடு. இந்த ஸ்ட்ரீம்
நைன் பண்ணிடுறேன்.
Wonderful session, ma'am. I was just listening and it was really a wonderful session. Thank you so much, ma'am.